Our final segment is coming up right now, and that is the breakthrough technology of osseointegration. It's my pleasure to welcome Dr. Jeff Cain, who's a family physician and teaches and practices at the University of Colorado School of Medicine. He's a past president of the American Academy of Family Physicians and co-founder of TAR Wars, the National Youth Tobacco-Free Education Program. After a bilateral amputation left from trauma 20 years ago, Dr. Cain has continued an active life that includes flying vintage airplanes, long-distance cycling, adaptive skiing, and winning the gold medal in the slalom in the U.S. National Adaptive Snowboarding Championships. Dr. Cain's a passionate champion for amputee advocacy and served at the Amputee Coalition's Board of Directors and a past member of the Medical Advisory Board.
Thank you.
All yours.
The clicker?
Clicker is right there.
Great. Thank you very much. I have to say, I'm really excited to be here because this is the first time I've been at this leadership meeting, and this is really about looking forward and creating a future. I think that it's, hang on a second, let's go back for a couple. And I was listening to the earlier talk, and when we talked about how to make things different, Peter Thomas said what you're really talking about is you want to start a revolution. And then I talked to Jim Weber, and he said, I think we'd do better if we could come together as advocates. But I talked to Mac McClellan, and Mac was like, you guys are ready to partner with us? Get back. But it was really Dave McGill that whispered the gentle words of wisdom to me. He said, we'll do better if we get by with a little help from our friends. So, so sorry. And I've got to admit, I think it's getting better, a little better all the time. So, but what we're really here to talk about today is a transformative technology, and that's osseointegration. There's a lot of buzz right now about osseointegration. How much buzz? You can see there are articles on about every other issue in motion. Here's examining the pros and cons. In your own trade journals, here's articles about osseointegrated and O&P Edge. This is an advertisement from a prosthetic office, a Step Ahead Prosthetic, looking for patients that want to have osseointegration for above elbow, for people that are below the knee, and for people that are also above the knee. Here's a television shot. Army amputee takes their first steps on a breakthrough permanent leg implant. And I don't think you can go to, and I think the rule is now, if there are 4 amputees in a room, one of these people has to show up from the Australian group. Because it seems like every amputee meeting, every prosthetist meeting, there's a booth from the folks from Australia that are there every single time. So my hope is that we're gonna have a quick conversation with you guys to do 5 things. First, I'm gonna catch you up a little bit about where osseointegration came from and where the science is currently on that. Secondly, we were talking about the importance of research. I'm going to give you 5 papers that came from the last year that update you on the most current literature about cost and about outcomes that matters to patients. My partner, Brad Ruhl, will be giving a chat about what it means to be a prosthetist, both in terms of billing, reimbursement, and how you need to think about those folks when they walk in. Also, he'll give us a talk about industry perspective, about is there risk for doing this to you, your practice, and to the amputee. And finally, we're gonna walk through a hypothetical case presentation with a patient that decided in the United States to go away outside the United States and come back, and what that experience has been like for that person. So, osseointegration is when you are having bone integrate with an implant device and directly attaching that device to a prosthetic foot or ankle or arm or hand. The designer of osseointegration, Brandon Mark Sr., designed this for dental implants. If you remember, a dental implant is put in with a screw. It's then set in a closed way, and then a cap is put on that looks like a tooth. When they first started doing this back, my father's a dentist and was doing some of this at the beginning, they all failed. And then after a little while, some of them failed. And then after a little while, most of them succeeded. And right now, almost every dentist in the block is advertising that they could put in a dental implant. And these are a screw-based technology. So the primary target is actually above-knee amputees with above-knee prosthetics that have been having difficulty with a socket fit. This is what it looks like. When you have an osseointegration device, you have a piece of metal that sticks out of your body for the rest of your life, and it goes on and off about that quick. They actually put it on. It's a 4mm screw. They bolt it on. That's how fast it is to take the prosthetic device on and off wearing that. It eliminates the socket, and it directly attaches the device to the bone. We'll talk a little bit more about the risks and benefits. Things change, though. So the first studies that were done with osseointegration started in Sweden. This is the son of Brandemark Sr. This is Ricard Brandemark. Between 1990 and 2008, they did 100 surgeries, and you could see it at the end of that time period, they only had 2/3 of the people still wearing the device. We're not going to go through because of time. I can see not only are we getting in the way of your next coffee break, it's getting in the way of happy hour, I heard. So the important thing to know about Brandemark's device is it's actually a 2-stage device. What he does is he implants an implant inside the bone, closes that up, and then the amputee lives for 6 months without wearing a socket, without wearing a leg on that side, and they come back, reopen, and put the abutment, the piece that attaches to the implant to the foot. And then in Brandemark's, they wait approximately 3 months before they're starting to walk more, and 6 months before they're actually up and return to activity. The most important thing about this right now is that they have now started FDA trials inside the United States. There is no device that is FDA approved. There are exemptions for custom devices on a very limited basis. This is going to be done in the UCSF in San Francisco, and they will continue with the same kinds of processes that he is using and talked before. A 2-stage surgery, 6 months between the implant and when they attach the abutment, and approximately 6 months additional before they're released to full activity. It uses a screw-type implant, and it requires a custom device to connect the implant to the rest of the prosthetic. Another pioneer, I'm going to touch the 4 pioneers worldwide. Horst Aschoff in Germany created a different type of a device that used similar technology as what you use for hip or knee implants, that have a roughened surface, and they put them in and press fit them. Aschoff continued to use the 6 months between implant and when you started to walk at first. His initial trial between 2003 and 2011 actually had, out of 54 surgeries, he had 9 early and 9 late infections, but then he changed his device so that the end of the device is now shiny and doesn't have the porous surface on the end, so the skin does not adhere to the end. And the difference is thinking of the opening as more of like a stoma rather than like a sealed surface. What they found is when you sealed the implant, there was a sealing in of germs, and if you allowed that to stay open, the germs would usually flush out. And in his last series of approximately 100 patients, he's had 1 failed implant and 5 fractures, and does not report any deep infections. Another group that's doing this is actually in Holland. This group uses the Australian device as their implant. I'm mentioning them because these folks have actually done a good job talking about research, as we'll see in a moment. They're following their patients, they have a rehab protocol, and they've done almost 200 surgeries. The person that shows up at all of our meetings is from Australia, Dr. Almuderis. Has done the most in the world at this point, approximately 300 surgeries. His initial series was a 2-stage process, very similar to the German technique, where he would use a press-fit device, seal it, and then put the implant. His revolutionary change is starting about 4 years ago. He started with a single-stage press-fit, where he would drill and put the device in. You can see he's done, you name it, it's an alphabet soup. He's done almost everyone and is aggressive in terms of being able to try different kinds of osseointegrated devices. What's different with his technique is it is a single stage. He implants it, and he starts a limited weight bearing unloading on day 3. That means he's doing it with very limited weight with a scale, 5 kilograms, wait 2 days, 10 kilograms until you're at half the body weight. He starts an above-knee amputee walking on crutches at 3 weeks. After another 3 weeks on bilateral crutches, he moves him to 1 crutch, and at 9 weeks, the person is released to home rehab without crutches. It's a fast rehab. Worldwide, you can see we're up to almost 1,000 cases of osseointegration. It's sort of like this alphabet soup again. The OPRA is the Swedish two-stage device that is the screw base. There's approximately 230 people living in the world with that. The ILP is Aschoff's direct implant with the press fit style. You can see there's a couple teams in the United States with Utah and also one that's in Pittsburgh that's trying to use a compress that puts tension on the bone. The OPL process includes Australia and also Holland in that load. So why do people go through this? First off, there's no more socket. Think of the socket, especially for a above-knee person, when they want to ride a bike. They're going to sit on a flight. They're sitting on that. The heat that they have, the rubbing that has on, there's no problems with skin interface. They're having a much larger range of motion. There's directly attached to their skeleton. What you'll hear from these folks that have had this is that it really feels like it's part of them in a different way. They can feel the surface. That's what osteoperception is. They can tell when they're walking on grass or carpet or something that's a core that they step on. Studies have reported, and we'll talk about those in a second, that people that have had osseointegration report a higher quality of life, improved gait, and improved step count. But it comes at a risk and a giving up. If you're somebody that is choosing to have osseointegration, you have to understand that there are some risks for you as an amputee in your life, and then there's also some surgical risks, and I'm going to separate those two. First, these devices are new, and we don't really know how much impact and torque they can take. Right now, they recommend if you have this procedure that you don't run, you don't do high-impact activities or high-torque activities. Remember that osteoperception? I said that you could feel things as an advantage. They feel everything. That means that vibration, heat, cold, those kinds of things. Sitting in an airplane for an hour can sometimes bother people to change their patterns. Swimming is limited. Swimming is a vector to be able to have germs come in, and they recommend not going in public pools at all. Ironically, they are cleared to swim in the ocean. I always thought that fish did stuff in the ocean, but it turns out that the salt water in the ocean is actually helpful for their skin there. There's a piece of metal that sticks out of the body for the rest of their life. And that's hard for a partner. There actually were 2 cases in Germany that Aschoff did. They did the surgery, and they came out, and there were 2 women, and they looked down, and they said, I've got a piece of metal sticking out. I don't want that. Take it out. And they redid the surgery, so they went back into a socket. It seems crazy, but it's a change in body image forever. The other thing to know is that it's really, really important that the prosthetic is aligned very, very carefully. It's even a slightly different prosthetic. When they first started doing BKs and they used traditional alignments, the forces were torquing on the inside of their knee, and they're causing medial knee arthritis at a really rapid rate. So they have to be able to understand how important that alignment is, and even using the laser systems. There are also surgical challenges. There is a risk of implant fractures, bone fractures, or loosening. They can loosen if there is an infection that gets in that interface. There is a risk of infection. It's hard to say the numbers because we just talked about 6 different systems over a bunch of different timelines. The best guess is, I'm going to quote these from the guesses, is the best guess is that you're looking at a 30 to 40% skin infection rate that can be treated with oral antibiotics. About a 10% rate of having to have IV antibiotics that's curable. About a 5% chance of having to have a surgical debridement, and somewhere around 2 to 4% to have that device removed. If it's removed, it may potentially be cured and then have another device put back in, but that's a significant risk. There's also, you're having a surgery, you're having stomach care, how to take care of that interface. The pain report has not been entirely reported, so that's the folks in Holland say that there's an amount of residual pain after a year that's not being reported by some of the folks that are in Australia. And it's not covered by the US. It's not an FDA-approved procedure, so people that are doing this currently are choosing out of their own savings to be able to go and do this. In other countries, it is covered in Germany. It is covered by some Canadian provinces, and they fly there and have it covered. Canada is currently considering including this as a surgically covered procedure. So complication rate, one of the things I think that's interesting to look at is when you look at the complication rate, that this is the report from Almuderis, who reports that there is approximately 2.6 in the red in his two-stage and also in his single-stage events where he had to have the device removed. And that seems high in some ways, but the rate of revision rate from a total hip implant is actually about 1.3%. So the numbers are getting pretty close right now. And what he's suggesting is that those rates are close enough that that actually could be something that should be considered as an alternative to the socket, especially for an above-knee amputee. I can't emphasize this enough. This is a list of all the things you could do in a socket or with a meat leg. These are a list of low activity activities, things like walking, biking, bowling, moderate activity, things like skiing, martial arts, and high impact activities like running, competitive sports. Most of you in the room have the goal of being able to return your amputee to full function and do all of those things. These are the things that you're not supposed to do. There is a bit of a wink-wink that's going on. I don't think that's truly honest, where sometimes the folks in Australia will say, well, we don't recommend running, and then they'll show a video of somebody running. And we don't recommend that. Well, we don't think you should ski, but we can devise a device to put on top of that, experimental device that you've got in your leg, to put an experimental one of a kind on top of that that might protect you. I don't believe that that's an intellectually honest procedure. So that's a little bit of the history and the status of where we are in terms of the science and the introduction of this technique. I'd like to then move to what I suggested. There are approximately 5 outcome-based research articles over the last year, and one that's 3 years old I think is worth sharing. This is an article from this last year that really looks at this is from Disability and Rehabilitation Journal. It is from the Dutch group. And what they suggest here is that please don't, you're not going to be able to read the detail there, but what it does say is that there is now evidence that bone-anchored prosthetics result in higher quality of life, function, and activity levels compared to a socket prosthesis. And that's these are outcome-based peer-reviewed journals. This is an article that's actually in the AOPA journal that looks at cost comparison of sockets versus bone-anchored prosthetics. It's a bit of a challenge because they don't include the surgery or the implant in the cost. It won't be a surprise to you to learn that if you have a person that already has osseointegration and you're making them a prosthetic device, and if you have to make a socket and the same componentry, that the person that already has the implant is cheaper to fit. You don't have to create the socket. And that difference is between $2,000 and $18,000 depending upon the socket and the cost outcome. There's 2 cautions they talk about in this article. One of them is that the cost of the implant and surgery isn't included. And there's also an industry, that connector piece that usually has a safety release for torque that connects the implant to the prosthetic foot and leg, is something that's not included in that cost estimate either. This is a research article that looks at bone density. If you put a metal piece in there, you're changing the way that you're carrying the weight, and that increased rate stresses the bone in a way that's healthy. This article shows that 1 year and 2 years after putting the implant in, the bone around the prosthetic device that's implanted is actually thicker than before the surgery. There are 2 articles that predate this that say, in addition to looking at the bone there, bone density of the back and of the hip, the femoral hip, neck, it actually increases with this device. Here's an article from the Archives of Physical Medicine and Rehabilitation. I think this is the one that's actually a couple years old. This is, again, the Dutch program. What's interesting about this is not only did they measure step counts, but they also measured oxygen consumption for someone that's walking with an above-knee prosthetic. And they found that person that has an osseointegration has a lower oxygen consumption for the same amount of work than person that's wearing a socket. This is a paper that was presented. Many of you in the room know Bob Gailey. Bob's one of my heroes. Bob, instead of comparing people pre and post osseointegration surgery, Bob compared people that are doing well in a socket to people that are doing well in an osseointegrated device. At the Amputee Coalition meeting, it's a small study, but when you got 20 people side by side with good prosthetics that are working and people that have good osseointegration, he found that the above knees had better proprioception. He used the plus M technique. You guys, I think, know what that means. I don't. And when he compared the transtibial amputees, the transtibial were equal between a socket and an osseointegrated device. And the people that were transfemoral did better than the person that's in a traditional socket. If there's one article that you want to go look and grab and learn about osseointegration, this is from November of 2017. It's not often that in grand rounds I get to quote an article that's 2 months old. This reviewed all of the journal articles around osseointegration and has 14 different ones that qualified that actually, who is the researcher that was just up here? He would approve of those 14 articles. And what those 14 articles summarize at the bottom, they say that there is now the time to move osseointegration from experimental to something that is actually a process that can be done and integrated as an option for people that are having difficulty with their socket. The evidence can be done from level 1 through level 4. This is the challenge that we have with osseointegration research is it's hard to do a double-blind study, right? Because you can't compare somebody that's got something sticking out of their leg and say, we're going to put you randomly in one or the other. So you can't do that. I will also say there's never been a double-blind study for parachutes. So do parachutes work? I don't know if parachutes work because we've never been able to do a double-blind study because no one will sign up to be able to have no parachute or yes, a parachute. So what we found out is on this article, it tracks the history of osseointegration. It talks about the research about outcomes, and I think it's a very good review. And the take home is that this is from the Canadian researchers who are considering introducing this device into Canada as an acceptable surgical procedure. And that's a pretty strong statement from them. So my hope was to introduce you guys to a little bit of a history of osseointegration, tell us where the science is, and catch you up to speed with the current research. And I'm going to turn over to my partner here, Brad Ruhl.
Thank you, Jeff. So I want to just share a couple of slides with you. I won't take a whole lot of time. As Jeff had covered a little bit, that there has been some movement in the U.S. with regard to Dr. Brandemark's firm. He's established a company in San Francisco. The company's name is Integrum. Ottobock has partnered with Integrum to provide the connector. It's called the Axor Connector between the implant and the external prosthesis. And so we're getting some very early experience with regard to how that's being delivered into the market. Today, some of that has been delivered as a part of the surgical implant, but in the future, we see it as something that will be delivered by the prosthetist. And time will tell as to exactly how that will work for us. But this, Integrum received humanitarian use device designation as a review through the humanitarian device exemption process with the FDA. So this particular device, the OPRA device, the osseo-anchored prosthesis for the rehabilitation of amputees, has been authorized by FDA. And it's the only device that's been authorized, and it's only for transfemoral amputations today. But the way that we are looking at this in terms of how this will be billed out is that the actual connector, the Axor itself, will be delivered, we think, much like a preparatory prosthesis. So there's no socket, but this connector will be billed out at this point. We're recommending it would be billed as a miscellaneous code. And then once the patient is through the second stage surgery, the rest of the device would then be billed as the definitive. But it would contain, obviously, just the knee, the foot, the connective componentry, and any cosmesis. So nothing too earth-shattering, but that's kind of the plan. That's how this will be set up today. It's exclusively being offered through UCSF. Integrum is choosing where they will go next. The next likely site is Walter Reed. And from there, I think they have a number of sites that they've targeted around the country that they will make this available through. So it'll be a relatively slow process. And that's about all I can really share with you. It was interesting, I was at, and some of you were at, the Innovation in Amputation Surgery and Prosthetic Technology meeting that was held at Rehab Institute of Chicago 2 years ago. There's another one coming up. I'm putting in a little plug for it in May of next year in Vienna. The whole topic of osseointegration surgery there was quite a hot topic, and certainly looking at opportunities not just with lower limb, but upper limb, as Dr. Cain had shared as well. But that meeting is a very interesting meeting for those of you that are interested to go to Vienna, Austria, in May of next year. I would highly recommend it. There's a lot of really great information that is shared there. So just a couple of thoughts here about the industry and the perspective. How does it fit in clinical practice today? Is it a threat? Or is it an opportunity? There certainly are concerns about risk. There are concerns about the threats to the role of the prosthetic provider. The magic has always been in the delivery of the socket. And when there's no socket, where's the magic? And I think that's a challenge, that's a question. It's certainly not something that's for everyone. The way that this was set up and approved by FDA was to address the very fact that this was for amputations above the knee for those who have rehabilitation problems with or cannot use a conventional socket prosthesis. So it's not intended to replace the conventional approach. It's really intended to be for somebody who simply a conventional approach has failed and they're not able to tolerate the socket. So where are some of the opportunities? Where are some of the risks? Clearly, we have received now information directly from FDA that there was a question about whether or not the use of the Class 3 implant would relate to the entire prosthesis and make the entire prosthesis then considered a Class 3 device, which would create a whole lot of hurdles for everyone. They have confirmed that that is not the case, that the fact that we're marrying a Class 2 device with a Class 3 device doesn't make the whole device a Class 3. So in that regard, there is no negative impact on the role of the prosthetist with regard to essentially the current exemption that we operate under. There's really no inherent increase in liability risk from fitting osseointegrated users. However, there may be patient risk that is increased, and I think Dr. Cain alluded to that as well. And while there have been infections, rejections, and even implant removals, we're not aware of any actual revisions that were required. And I may be wrong there, but that was just something that was shared. And why would I do this if I was a prosthetist? Why would I offer this kind of care and this opportunity to my patient? Well, for those who want to differentiate and be sure that you're offering the full spectrum of rehabilitative opportunities to your patients, it's clearly an opportunity. Training and services being coordinated together with our professional clinical service team. We work together with the folks from Integrum. They provide service on the Axor Connector. We provide service and support to the prosthesis, the definitive. And that's really about it. It's very early. There have only been a handful that have occurred thus far at UCSF. But it's been a long process, and I expect that momentum will start to build. So, Jeff, thank you.
When he said that there's a handful in the U.S., there are approximately, at the best count we could get, approximately 100 people living in the United States have had osseointegration surgery. And so we thought it might be helpful to this crowd to be able to say to give you an example of someone that's had this surgery. Somebody comes to your office and wants to talk how that was thought through with a prosthetist here in the United States and what happened. So I'm going to talk about a 58-year-old male that had bilateral below-knee amputations from multi-trauma. Had the usual story, 2 weeks in an ICU, 2 months in the hospital, had one leg removed. Let's back up. So this surgery occurred 1 year ago in Sydney with the Oprah system. The patient had multi-trauma approximately 20 years ago, lost one leg below the knee at the time of the accident, had the second leg removed electively because of trauma to the calcaneus and the tib fib on that same side 6 years later. Did very well in sockets, did a first triathlon, short course triathlon within 1 year of the second prosthetic leg. Was able to go back to water skiing, won a gold medal at the National Disabled Snowboarding Championships, and fly small airplanes with a prosthetic device. This person was promoted professionally to associate professor at the University of Colorado, was president of the American Academy of Family Physicians, and was just elected chair of the Amputee Coalition. That person is me. Why? I have to tell you that I had tremendous success in sockets. I have and had a very extraordinary life, and I'm fortunate for it. I went from 1 week in the ICU making rounds on patients to the next week being a person in the same bed, not certain whether I was going to live or die. And what I will also tell you is the lessons from walking that path have helped me as a physician, as a leader, and it put me in places, including in front of this room, that I don't think I would have been doing many of those things ahead of time. And I did that. Why? How? I was able to do that because I have a prosthetist that's outstanding. He literally says to me, "What do you want to do, Jeff?" And I said, "I want to water ski." And nobody was water skiing with two prosthetic legs. And we did that. And I said, "I want to snowboard." And we built a snowboard, an adaptive device. And we were snowboarding when people were telling us from the adaptive sports programs that you can't do that standing up on a snowboard. How did we do that? We also did it because that we had the right prosthetic devices, the manufacturers, the feet and ankles. I will say this time and time again, you can't be successful as an amputee without a motivated amputee, without an outstanding prosthetist, and without a manufacturer that can create the products to be able to help us live outstanding lives. So why the heck would I do this? I have to say, it works great until it doesn't. I had tremendous success for about 15 years, and then I didn't. During my term as their sentence at the time with the academy, I started to have a small problem with the discomfort of the medial flare of my leg. And it started to get to be more and more of a challenge. It wasn't just discomfort there. It was actually, I was having a sweating and probable thinking. One rehab doc said that was because I was having pain and I was trying to choose not to feel it, but I couldn't choose not to have those sensations. It went from being just a little metal fog to having those symptoms when I had the leg on and was standing, and when I had the leg on when I wasn't standing. I went from doing a short course triathlon to less than a block of walking, 1 or 2 minutes of standing. And when I would see patients, I would drive my car to the office with the leg partway off. I'd get out of my car and I'd push the wheelchair and take my leg off and see the patients with my leg off on one side. And we gave it the good old college try. I'd spent approximately 2 years, and you can see I saw 4 prosthetists that you guys know. I traveled. I had 30 check sockets in about 2.5 years, 14 interface, elevated vacuum, expulsion valve, pin systems, strap systems. I had consults with 5 orthopedic surgeons, 4 rehab docs, 3 sports medicines, 7 physical therapists, 6 weeks outside the leg, crutching around on a prosthesis, 4 injections, 1 MRI, and a partridge in a pear. Sorry. We gave it the good old college try, and I was thinking that I was going to have to spend my life then with a readjusted understanding of what I could do physically. And I happened to be at the Amputee Coalition meeting, and I watched a baloney person walk by with osseointegration. And in my brain, I was thinking about osseointegration 5 or 6 years ago, which was what was happening before, where it was the early stages. They were above knee folks. Some of them lost length of their leg when they had to pull it back out. And that was scary to me, and I didn't think the technology was ready. And then I was fortunate to saw some of you folks at the OPA meeting when we talked about introducing collaborative efforts on advocacy, talk to your board, and I was in the room when the people on the stage included Munjat Almuderis, Ricard Brandemar. Ricard was not there, but had team members there. Horst Aschoff was there, the Pittsburgh team was there, and the researchers from the University of Utah were there. So I spent approximately 6 months and about 1.5 inches of paper doing the background research to say, when are we ready to do this? I have a brother who's a research surgeon in pediatric urology. I called him up and I said, Mark, when do patients, when he does research stuff, and he said, you got to do about 50 before you understand some of the risks and benefits. And I found that these folks have done more than 50. When I looked at those studies to be able to say, what are the risks of this? I thought it was something that I could do. So I went to Australia last year in December, and had bilateral osseointegration surgery. I decided if you're going to do one, and it's supposed to be, and I'm going to be limited by that side, no matter what, I might as well do two because it promised a step up in terms of what I could do inside those limits. These are my X-rays. You could see I had a Ertl on the one side, on the right-hand side. Ertl's a hard thing to say because there's so many different kinds of Ertls. I was never able to end bear on that. And Dr. Almendares looked at the size of the tibia there on the left, thought it was thin, fractured the fibula, moved it against the edge to be able to give implant thickness. You'll see that that's a fairly good size rod. Those are actual femoral implants. They're bigger than a standard tibial implant. It allowed us to do that without putting in the cross screws. If you put in a cross screw, you're not really fully integrated. You've got a stress riser from a cross screw, and we thought we'd do better with that. So help remind me what we said the complications could be. The chance of a skin infection are what? About 30 to 40%. I had a skin infection. I was on oral antibiotics for a couple weeks. And there's a chance of having to have a higher level infection, wasn't there? About a 10% chance of having IV antibiotics. I had IV antibiotics. I had infection that was not being treated by oral antibiotics. We said there's a chance of having to do maybe a surgical correction, about a 5% chance. I didn't have to have the device removed, but I had to have a debridement. That piece of tibia that was moved there became avascular, and they had to go in and take out the anterior compartment. You don't use an anterior compartment when you don't have a foot, by the way. So that did not really make that much difference. But the difference that it did make, and that meant that I had additional 2 months of not weight bearing being in a wheelchair. It meant that I had a different rehab protocol. I will tell you that they're learning that the tibias require a slower progression than the fibula. The fibula has thicker bone, and that allows that faster recovery period, and you need to probably double the recovery time for BKs. So that's 6 months of limited weight bearing, 6 weeks of limited weight bearing, 6 weeks of bilateral crutches, 6 weeks of unilateral crutch. And that delayed it quite a bit. So there's on the other side, you can see this is an X-ray from about last month. You're going to ask me, you realize when you do research on folks that choose to do this, they've invested themselves financially and emotionally. When you talk to the folks that are at the Amputee Coalition or at your meeting, those people they're almost rabid converts. It's like a kind of a religious experience, the way that they talk about it. I don't think you should ask me how'd this go. I think you should ask Pat. Pat, by the way, that's the most wonderful woman in the world. She went down to Australia with me, and this is actually a month and a half ago in Austria when we traveled. So Pat would say there's some differences that she noticed, and on December 14th, 2017, Pat wrote me a letter and said, here's some things that are different. So my face is different. She said when I was standing up and sitting down, my face had pain in it all the time, and I was fighting it. You guys might have seen me at meetings here when I would stand and talk to folks and I'd start sweating. It wasn't just because the room was hot, it's because I was trying to be the right thing for the Amputee Coalition by talking to everybody in the room that could help build this advocacy project. Because I've discovered that there's something more important than pain. You can do almost anything. At Christmas is different. So Christmas this year, we went and we walked around the small lake in the park next to our house. That's almost a mile, and I could feel the snow crunch underneath my feet. I hadn't felt that for 20 years, and that was a mile. And then we came home and we baked, and we hung out in the kitchen. I used to have, for about 15 years, 12 years, I've had a stool in my kitchen. I couldn't wash dishes without having to sit on the stool. And that stool's still in my kitchen, but it gets in the way now because I'm not using it at all. So there's another difference. My clothes don't fit. I've lost about 10 pounds, 2 inches of waist size because I'm using my body and I'm being active in a different way. Pat tells me that I'm not as hot as I used to be. I think she means that when you're wearing a suction device with elevated vacuum, you've got sleeves all the way up to your waist. It's essentially like being in a wetsuit all the time. And it used to be that I would be hot and sweaty all the time in a room, and now, for the first time in my life, I'm noticing when it's cold outside. I was taking my Vespa when it was 20 degrees and riding around because I didn't feel cold because of the gel liners and the prosthetics and those kinds of things. And now I can only ride my bike down to the 40s. In terms of travel, she said when we went to Australia and when we went to Austria, there was a difference in what I packed. I used to teach adaptive skiing internationally, and I would have to bring 2 extra sleeves of tubings, 2 or 3 pumps. Right now when I travel with this. And that's the device to be able to take this on and off. It's a difference in terms of the amount of hassle factor. There's some things that I don't do. I put these all under the Colorado list. I've been a big biker all of my life. I still bike, but I bike right now on smooth surfaces because when I ride off-road, I'm at a year. I'm hoping it's going to get better, but I can't take right now being on that single track that hammers you like this. Pat has got a Jeep. When we go four-wheeling in the Colorado, I sit in the passenger seat and I take my feet off because otherwise it's going to be bouncing me all the time and I'm not going to like that. I used to swim twice a week. I no longer go to the swimming pool. I'm looking forward to, she wants us to go to the Galapagos, and I'm going to talking with Chris again, my prosthetist. I'm going to have flippers and I'm going to be out there looking for turtles at the Galapagos Islands. And the hardest thing for me is I no longer ski. I was skiing first on 2 skis and then with an adaptive device that I introduced with my dad all day at Vail, and I don't go skiing now. I made try to ski using a monoski this last year. And there is some bad news, Pat said, about this, is that my sense of humor has not changed at all by doing the surgery. So who shows up at your office? So the people that are going to talk to you about osseointegration are people that have said maybe I think the pros outweigh the cons. I think right now for below-knee amputees that are doing well in a socket, you give up a lot. If they're not doing well in a socket, then it's something you can talk about. You could probably make a case for above knees that the trade-offs are closer, and I think you're going to find a lot of people that are above knee amputees who are going to talk with you about this concept, especially now that's being done in the US. People that have challenging residual limbs that can't get in a socket comfortably are going to want to talk with you. This is Chris's term, my prosthetist. The John Glenn, that's Chris Hoyt, Biodesign Denver. The John Glens of the amputee world, people that want to be the first and out there. I'm a little afraid that there's so much press out there. There are people that are looking at being an amputee and jumping straight to this. I've advised some people that a guy called me that said he wants to think about going to have his first and second amputation at the same time and go straight into osseointegration as a bilateral. I said, what do you want to do? He said, I want to hang glide and I want to ski. That man should be in sockets. And also, I think that it's important to say that there's another category that I hate to say out loud, but there are some people that have never had Chris or never had someone that was able to put them in an excellent prosthetic. And that means the device has to fit, and it means the device has to be aligned correctly. And so there are some folks that have never had a good fit, and they may be jumping prematurely. So our hope today was to be able to catch you up with Osteointegration Surgery to talk about what's happening in the US, let you know that this is starting trials here. We gave you 5 different articles that are within 1 year old that talk about outcome data. We've talked a little about how to bill for it if it shows up at your office, how to think about it in terms of the prosthetic industry, and we talked about a case presentation. And we're getting you out of here under our time limit. So it's hard to compete with beer, isn't it? In that case, we're going to say thank you all for being here and staying awake and present the last time.